And then next, we're going to have Dr. Ben Gont, who is a clinical manager at the Tulele Hospital in the rural part of the OR Tambo district in the Eastern Cape. And he will be speaking to us about the socio-economic implications of TB in the rural setting and what can be done to improve the burden of TB in that setting. Dr. Ben.
Thank you so much. Can you hear me? I hope. I'm just... thank you for rearranging the program for me. I'm sorry. In some ways, that's the joy of rural hospitals, that you can be in theatre one moment and talking about TB the next. So that's my short advert for rural. But happily all went well in theatre. And I'm sorry I missed the first talk, but thank you. That second talk was really moving. It's always, I think it's always significant hearing from people who've had something, whatever it is. And I think especially TB, because we easily make peace with the existence of TB, especially in our country. There's so much of it that we almost kind of stop dreaming about a world without TB. So rural is my passion. As you heard, I'm at Zitulele Hospital in the Eastern Cape. So this is a very Eastern Cape kind of stats focused. It's not a lot of stats actually, but where there are stats, they're Eastern Cape. My passion is that rural people should have access to the same quality of care as urban compatriots. And yeah, the challenges of rural care are often very different, although of course we're just people like everywhere else. So yeah, these kind of couple of minutes are really just to hopefully help make you think about it from the perspective of someone who's living far away, perhaps from some of the fancy science or the kind of policy making that happens often in urban areas, and hopefully yeah, being the rural student, or what's it, rural support network, I thought, well, I was grateful for rural to have a voice. So this is a photo. My son got a drone for Christmas. So this is the photo kind of in front of my house, but from a slightly elevated perspective. And I think, you know, I mean, for anyone who's grown up or traveled in a rural area, this isn't particularly new kind of scenery, but for urban dwellers, I think it's easy to forget that this is how 40% of our country live. It's not all quite as beautiful as the wild coast, but there are other beautiful parts of the country. And the point is, it's very different. People live much further apart, which of course has some advantages when it comes to TB, but they also live uphill and down dale and far away from the clinic. And so accessing healthcare can be a real challenge. This is a photo from the 1950s, actually, taken in a very similar part. So I don't think it's the exactly same view, but it's a reminder that rural isn't static. It's a ever-changing, ever-densifying landscape, actually. And the problems, although they are similar to what they were, because it's the same kind of challenges, etc. And they do change with time, and populations change with time, and our opportunities change with time as well. So kind of keeping that in mind is important as we just kind of engage these 2 or 3 thoughts. And so this is our hospital, and hopefully you're not getting bored of the scenery. This isn't a recruitment talk, but you know, it's beautiful here. And the layout, this is literally how the landscape looks for about 1,000 square kilometers, which is our catchment area. And so some people live a lot closer to clinics or hospitals than others, but you don't have to actually be very far away for accessing care to be really difficult. And we know that people don't access care the first time they cough. They take sometimes many months and wait until they're really properly sick before they actually go to the clinic or go to the hospital. And if you misjudge that time frame. Getting there can be all. How far, where do you come from, and how did you get here today? And those are really significant, even when it comes to TB. Understanding where exactly your patients come from really makes a difference to how you both make the diagnosis and make a treatment plan. And I think in the bigger picture, it makes a difference to how we approach the problem of TB. There are two really helpful kind of frameworks that I think can inform one's thinking around rural healthcare. And this is the first one. It's been around for a while, 50 years. It sounds completely obvious. Those who have the greatest need of healthcare have the poorest services. It's a self-fulfilling law in a way. It just carries on. As you develop service positions for 100,000 people in South Africa, where there's 70, or rural parts of our country where there's 20, all feel busy and all feel like we haven't quite met the need. But the need, the unmet need in rural areas in particular, is substantial. And the realities of how people live. This is actually a picture of a chap who lives in between us and our southern neighbor, Madrileni Hospital. To get to Madrileni, he must cross that river over the cliff. To get to us, it's about a 40k trip, and taxis don't really enjoy that kind of wheelchair. So it's really, really tough getting to services, and as a result, also getting services to people. And I think that's really where we have to challenge our thinking. When we start to develop tools that we think are going to impact things, they've also got to be able to impact people who live in this part of the world. This is the second rural reality that I think frames thinking very well. So when I first heard about it, I was like, wow, that's really helpful to put words to reality. So the challenge of our country, the challenge of many developing countries actually, is that the parts that have the greatest health burden get the smallest share, not because we believe in inequality, but because the system is set up in a way that perpetuates inequality. So the Western Cape, I know we always give you guys a hard time there, the promised land. We're the land of promises, you're the promised land. The Western Cape is a relatively well-resourced, it's got good skills, and the system has been working, or is working a little bit more efficiently than it is to the east. And so what happens is that when you get money, you spend it wisely, more or less, and you can account for it more or less. Whereas we have fewer skills, we've got fewer people to start with, we've got fewer skills, and so we've got less capacity to spend that money. And when we don't spend that money, when it comes to the next year's budget, it's like, well, you know, the Western Cape spends their money wisely, and the Eastern Cape, hey, we don't even know what you guys are doing with it. So we give more to the Western Cape, and maybe even the same again to the Eastern Cape. But what happens when you multiply that year after year after year is that actually we widen inequality. And so the disease profile might be similar, the people might be similar, and we're a great place to do research because, of course, we've got a reasonable percentage of our population who've relocated to the Western Cape. So you can actually study allergies or TB or diet or whatever between parts of the Western Cape and parts of the Eastern Cape, and you can see a real difference. But of course, for the health of the people who are in the rural areas, it's a real challenge. Yeah, and I just thought this was a sobering table, to put it mildly. I think a lot of times we don't realize that these are the realities still in our country, and it's not just the Eastern Cape province. I highlighted a few because when you look at a table with lots of numbers, it's hard to see where you're going. But in the district that I work in, our Tambo, people over the age of 20, nearly 1 in 5 has had no schooling. That's incredible. This is 2021. You know, these are people who, some of the people in that category were, you know, weren't yet born when when we started with our democratic government, and we are still failing people in rural areas because it's difficult getting services. It's not because nobody cares or because, you know, government has forgotten. It's because it's challenging. You know, access to piped water. Look at that, 38%. That's really low. Households with a chemical toilet in Alfred and Zor, or no toilet, should I say. I mean, there's only 9% of people with a toilet. We read the stories of the horror things that happen at schools occasionally, but for many households, that's the reality of life. And so I know this doesn't sound like TB, but you know, when I was at varsity, I thought these kind of things were sometimes a little bit like, can we talk about medicine? Because I enjoyed the science of it, and you know, I wanted to learn how to make the diagnosis and treat it. And of course, that is really enjoyable, and it's fun doing the kind of the medicine parts. But TB, perhaps more than any other disease, is a disease of kind of communities and the places we live. And it's very different. You know, our population around our hospital, they don't spend time on buses, and they spend precious little on taxis compared to urban populations. They've got many advantages when it comes to the kind of outdoor living that is much more common in this part of the world. But the TB problem is still the same. So it's just that it's different. And I think that's super important when we talk about anything, frankly, any of those diseases. How we go about it is somewhat different if you're in a rural area. So you know, I could regale you with the unemployment stats or the household income stats. All of those make rural, you know, we don't want to also paint the impression or give the impression that rural communities are lacking, you know, the dignity of people who live in rural areas, and the forbearance and strength of people is just incredible. But it is tough, and we need to be thinking about ways to support rural communities. So, you know, you've seen graphs like this, and I think the challenge for us is that, okay, great, we saw TB incidents start to decline when we made ARVs more widely available, but we haven't really made a big difference in the last 10 years, well, 8 years. We know that the prevalence survey puts our TB rates is even probably higher than this. And we face real challenges in getting this number down. And so the challenge is, you know, how do we do this? And there isn't one magic bullet. I'm sure the other speakers have said that. You know, we need to think about how do we deal with geography? How do we deal with infrastructure? And each province is different, eh? I mean, the Northern Cape, wow, there's miles and miles of straight roads, but if you're wanting to get anywhere, it takes hours because it's far away. Here, the problem is that Gogo can't climb up the hill because she's short of breath. But geography is super important in rural areas. Infrastructure, that's both the health infrastructure and also people's home infrastructure. Many people living often in small spaces. Roads, we've spoken about. People, I think, you know, people are both our challenge and our resource. The challenging part of people perhaps in rural areas is migrancy. In our part of the world, you know, we can put a huge amount of effort into TB and then have them go visit or have a visit from a spouse who's working in the mines, and then we're back to square one if the mines haven't also addressed TB, where we're linked together. And education, you've seen that stat, and obviously how people then engage with TB, etc., is influenced by that. So the last question is really, what are the implications? The new model, we're very much trying to think along the lines of zero TB. Hopefully you're aware of that initiative. That's the kind of partnership of like-minded people around the world. It's not a formal organization. But where we're saying we need to do search, treat, and prevent. And I think for us, search is a big part of it, because we do reasonably when we get the sick patient in our OPD, we know how to treat them. We don't do prevent very well, and we don't do search because we get put off by distance. So I think we need to be thinking in terms of a new model. I like the little bit I caught about a vaccine. Wow. Yeah, and the comments about it, how contrasting our approach to TB and COVID are sobering. And I think we need better data, and we need to think of ways to collect that data reliably in rural areas, particularly because we don't have network. In fact, thank goodness for Wi-Fi. Somehow I have Wi-Fi in a rural area, but I've got no cell phone network today, because we've had an all-day power failure. Eskom wanted to remind us about the potential for load shedding. And lastly, the implications are, especially for students as part of the rural support network, we need people, we need you to come and join us and be part of the fight, not just against TB, but to make the world a better place in the rural parts of our country. I hope that's just given you a little bit of a taste of how kind of our approach to TB is slightly different in a rural setting. The disease might be the same, but rural is different. And it's a wonderful, wonderful challenge, but it can be tough at times. And I think what I love about these kind of connections, hearing from people working in very different settings, is remembering that we are the sea, and thinking of new ways of tackling old problems. And yeah, that's what we're doing in our little part of the country. Thanks so much for the opportunity to chat to you, and your patience for me arriving late. Thanks.
Thank you so much, Dr. Gont, for that. That was very inspiring. I'm sure many of our students are going to want to come to Zitilele afterwards, or for placements, hopefully. So now we are moving on to the Q&A section. In the chat, there isn't many questions. There is one comment from Dennis Awane. He says there's an urgent need for advocacy from all actors, from civil society to TB-affected communities to scientists, to increase support from national governments and donor agencies for TB research. I'd like to open the floor for anybody else that maybe has comments or questions for the speakers, or just to create conversation. You're welcome to put up your hand and speak. Prof. Scriber?
I have a question for Ben, if I may. Thanks very much for that great presentation. Is there any way that we can partner to achieve something together? I mean, is there something that you can say with immediate effect? Yes, this is what we could do together. Obviously, what we do is research, which may not necessarily be easy to implement or to work together on, but I just wanted to ask that question.
Yeah, thanks very much. To be honest, a couple of sentences in the first half of your question went missing with my connection. But I think that's research in rural areas is super important. And in fact, we've got kind of a nascent little research center. One of my colleagues, Carl LaRue, who's been here since 2006 with us, has pretty much does research with the idea that we really want, we think good research kind of influences, it needs to incorporate rural perspectives. I think for us, a lot of the question that needs answering at the moment is, how do we do this for the kind of the least possible money, and how do we do it practically? It's quite hard to research it. I mean, operational research is challenging anyway, but getting kind of, it's trying to design something that has enough kind of extra capacity in from the outside without becoming Well, obviously you could do it. You had $40 million and you brought in a team of 100 people. Anyone can do it if you throw those resources at it. So on the one hand, we don't have capacity often in rural institutions to really do justice to the research, but equally, if we bring too much resource, then we almost skew the environment too much to make it applicable. Because I didn't hear the first half of your question, I'm not sure if that entirely answers it, but I think getting that balance right is important. And I think often partnerships are really from a kind of scientific or new insights point of view, but what we have to offer is the kind of the context of our patient and the context in which kind of policy or work elsewhere gets implemented in this part of the world, and hopefully that also adds value to the kind of research that one does in kind of bigger centers.
Just thank you very much. Just to provide that first sentence, I was basically asking whether there was anything that you could immediately think of where one could partner up to work together on something. But I think you sort of have answered that. And of course, operational research is enormous effort. You need people and you need the resources, and that would require, it's not something that one can just pull out of a hat.
Yeah, I mean, I think the one kind of specific question we have at the moment, looking at kind of search, treat, and prevent as a coherent strategy towards TB is, how much effort should we be putting in the search? Do we try and get to all those households? Is there a good return for investment on that, or should we be putting more effort into prevent? And which groups we know some of what works and what doesn't in theory in preventing TB, but when you implement it on the ground, given that you only have X amount of resource, where should you be putting it? I think those are the burning questions in terms of what do I do with what I've got.
Sure.
Ben, if I may ask a question as well about the last point over there. Do you have programs in place in rural areas, and how do you go about case finding? From those photos that you sent, it would look extremely difficult to go door to door. How do you do it for TB or for other diseases?
Yeah, so we've had probably much better success with drug-resistant TB than with drug-sensitive TB, which just felt like it was too big a problem, and our DR TB numbers were much smaller. And so when we got Gene Expert, obviously our ability to diagnose it improved a lot. And we immediately said, well, we're going to try and get out there and find contacts of DR TB patients. And so we literally, it's asking one of our TB nurses to go out with the driver, park and walk, and then get kids especially, and obviously any symptomatic adults in the household to come to hospital so that we can properly, x-ray them and take sputum and have a good look for it. And I mean, our DR TB rates have gone down quite a lot. And I mean, again, I can't assign causation to our home visits there, but I'd like to think that some of that is, but it's very resource intensive, obviously, to do that. We've looked at using our community health workers better. Carl has actually done some interesting research in terms of models to supervise them. And when it comes to policy, one of our big challenges is the disconnect between clinics and district hospitals. One understands why the primary healthcare system and hospitals are slightly separate in cities, but in rural, they really need to be more closely connected. The numbers don't work otherwise. And so I think I would like to see better collaboration between hospital and community health workers, because those are the feet on the ground. And they actually, in the areas where they committed CHWs, they do tremendous work going into people's homes, finding contacts particularly, and making sure that people who aren't connecting to care do get to care. Just, I mean, it's not TB, but it's a similar thing. We got funding through an NGO that we started actually to support the hospital and do this kind of work in the community as well. And we've got community disability workers in 7 of our main villages. And their brief was to go into, basically over time, to go into every household in their village and find disabled people, or people living with disabilities, let me say rather, because many of them are not needing even to access the health system, or sometimes it's they are completely cut off. And so that range of people, and the idea is that the CDW knows who has what challenge in their village and has connected them into what services they need, be it the health system, or be it grants, or be it employment opportunities and apprenticeships. And yeah, again, I mean, that's resource, but that we get quite a lot done there for relatively little money. So I think the feet on the ground in the village is a crucial part of that.
There's another question from Ihisa Names. What is the experience with mobile clinics in rural areas?
Yeah, mobile clinics are an interesting kind of aspect. They're often, we don't use them particularly much here. You know, we've got fixed clinics that serve, that are, you know, relatively accessible. I think the challenge with mobile clinics is kind of staffing and supplies and things. I mean, even our fixed facilities are struggling. So, and they're not a big feature of care in our rural area, but in some rural parts of the country, they make a big difference, especially the parts where there's really significant distance. That it's, you know, it's not viable or necessary to set up a whole fixed facility, but to expect people to travel is really difficult. So one of the HIV programs that was running in the northern part of the Eastern Cape, up in the mountains, they made quite a bit of use of mobile clinics, actually going to farm workers and other isolated communities. And I think that works. It also depends a lot on how people prioritize seeking healthcare for whichever aspect it is that you're talking about. We found, for example, that eye care, people didn't come to hospital if they got blind in old age. Well, there was initially nothing we could do for them anyway, but you know, now we've got cataract surgery and an optometrist, and again through an NGO partner, literally take eye care to people, and they definitely are much more likely to access it if you take it to them. And the same with dentistry, funnily enough. TB sort of falls in the middle, but we could probably do a lot more than we do.
Sorry, I have a question, Dr. Ben. You mentioned how you have the mobile clinics where you send assistants to, or the TB nurses to go find adults or kids with TB. And you also mentioned that they often do live very far from the hospitals or from the clinics. I want to ask, how does that affect treatment? Do you have a lot of patients that are adherent to the medication that complete their treatment? Do they have to come back to the hospital to get the treatment? Like, how does the success of the treatment work?
Yeah, that's a great question, and it's a conundrum at the best of times. We've actually just hoping to publish some of our data on that, because yeah, you know, the sick patients end up needing to come back to hospital. Of course, those are some of the patients that find it the hardest to get back to hospital, and the less sick patients often can continue care at their clinic. So from our numbers point of view, we send pretty much, if you're well, if we make a diagnosis at the hospital, if you're well, we're going to refer you to the clinics to continue your treatment. And so we don't, unfortunately, have good numbers on the outcomes of those patients, but we presuppose that they do relatively well because they were relatively well to begin with. And when you need them to come back to hospital, you push up your loss to follow-up rates, and you also make it harder for them. So it's more expensive and more difficult. And yeah, that's a continuous kind of roundabout. We actually, I mean, again, we've got something called the Patient Assistance Fund, which a bunch of kind of old and current team members contribute to. Because the reality is, you know, when you're asking someone to come back from far, a round trip taxi fare to hospital from some parts of our catchment area might be 200 Rand, and the household might be living off you know, between 1,000 and 2,000 Rand, and that might be for 10 people. So you're asking them to spend serious percentage of their income to come and see you. And while that might be really important if they want to survive their TB and CD4 count of 10, they, you know, they also have to eat. They stopped taking their treatment because they didn't have food. Because, you know, pharmacy probably said, you know, you should take this, you must take this treatment with food. And then people think, well, I don't have food, and therefore I don't take my treatment. And well, therefore I can't take my treatment. That's a very common problem when it comes to TB. And yeah, so one has to get that balance right. This person is well enough, hopefully, and you've got to trust the system. Well, you also have to build capacity in the system so that you can trust it.
Thank you, Dr. Bond. There's another question from Fuslari with regards to, it's more of a research question. So any one of the speakers from SAFI, Prof. Skriber, Dr. Mendelson, or Dr. Stiegler. The question is, are there any research opportunities available for undergraduate health sciences students in TB research currently?
Yeah, I can take this. In general, in terms of laboratory research, the best avenue would be as part of the intercalated BSc honors program. And I'm not quite sure exactly at which stage most students who are on the call would be, but if that is something that is still coming up, then that is always an option. And I think there are a number of people I recognize on the call who actually have gone through that. So that's essentially taking a year out to do a BSc honors, which includes coursework and a research project. You know, if there is other interest to do some research, I would suggest, I mean, it won't be possible, I think, to do that as a lab project, because that requires being physically present, and there's certain lab training and health and safety issues that one needs to take care of. So that is time consuming, but I think it is possible to do projects that are based on data analysis or research in terms of, you know, reviewing of literature and formulating reviews or analyses. And so the best way there, I mean, I can't think of any opportunities currently, but it's just to reach out and to say, you know, I'm interested in something. Is there something available? And I think that would be true of any research interest that you may have. There are lots of research groups that are around and that are always eager to engage in these kind of activities. I don't know if anyone else wants to add. If anyone else wants to add, yeah, please do. I note also that Valerie Mizrahi, who's the IDM director, the Institute of Infectious Disease and Molecular Medicine director, is on the call, and she may also be in a position to speak to this if she wants to. Val, I'm putting you on the spot a bit. Or maybe she's engaged in other stuff.
Okay, we'll wait a little bit for any response from anyone else. But in the meantime, I do actually have a question about the research you guys are doing with the TB vaccine. I was just hoping maybe you could speak a little bit more about that.
Sure. I mean, so the research program for TB vaccines is much more extensive than just that one example I showed. So at TATVI, we've been involved in, I think it's 28 clinical trials now over about 20 years. And in fact, we're just celebrating our 20th birthday as TATVI. And over those years, we've tested 9 different products, so different TB vaccine candidates, as well as BCG, which is, of course, the current vaccine, in different stages of clinical testing. And I'm sure everyone now, because of the coronavirus epidemic, is very familiar with the phase 1, phase 2, phase 3 type of setup. The resources available for TB vaccine research are obviously much lower than they are for COVID, but there's a number of candidate vaccines that are promising and that are moving forward in the pipeline. And I think besides the one that I presented, which of course showed very promising efficacy, there's also a result that was generated in South Africa and we were heavily involved in this, where we tested whether giving BCG again in adolescents who are not yet infected with TB can protect them against becoming infected with the bacillus, which also showed a certain level of efficacy. The trial wasn't enormous, and so there's a current ongoing trial, a multi-center trial in South Africa again, to do this in a larger sample size. And so hopefully in the next 3 years or so, we'll have the results from that. And it might actually be possible that we could influence the policy to perhaps give BCG again in adolescents if it turns out to be beneficial. But other than the M72, the GSK vaccine that I spoke about, there are a number of other products, including actually new vaccines that where the aim is to replace BCG and to give a different type of vaccine to infants to try and get perhaps better efficacy, so protection against TB in children to a greater degree, and perhaps even one where the protective effect lasts longer and it might even be able to protect into adolescence. Although I think that's going to be very difficult to achieve. Yeah, so there's a lot ongoing in the sort of global TB vaccine research agenda, and many of those trials are actually happening locally in South Africa and in the Western Cape. And so, yeah, it's slow going, but I think it's an exciting field and definitely more and more success coming through. So if you're interested in that, we were happy to tell you more.
Okay, thank you so much. Are there any other questions for any of the speakers from the floor? You're welcome to put up your hand.
Everyone's very shy. Come on. It's also been a long day, TB day. Lots of presentations. I guess there's a bit of Zoom fatigue. Well, maybe I could just say thank you very much for setting this up. I think it was great. I certainly enjoyed the other talks, so very well done to the others. I learned a lot, and I think it was really excellent for me. So thank you very much to be part of this.
Thank you, Prof. Skibo, also for accepting the position of being one of the speakers. Also, thank you to all the other speakers, Dr. Mendelson, Dr. Stiegler, and Dr. Gaunt. They were all very good talks. And thank you for SATV for co-hosting this event. It's been a long time coming. We had many plans last year, and because of COVID, everything was just postponed. So we finally starting off and kicking it off this year. So hopefully there's more collaborations with SATV in the future as well. I'll hand over to our events management team for closing if there are no other questions.
Thank you so much, Anissa. You have already started us off on closing up, actually. So we've come to the end of our talk. Thank you to our speakers and our listeners for coming through, and to each of our speakers for sharing their experiences of being vulnerable with us, and also sharing the importance of TB research and how it is important to address all the socioeconomic factors. I'd also thank the listeners who wrote to us, like the questions, and thank you for all the contribution that you have made. And I don't know, I think I'd like to thank Satfi and Dr. Gant for all the work and research that you continue to do in the world of research and making sure that TB knowledge is growing. And we as RSN are looking forward to working more with you in the future. Thank you.